There we go. I answer a couple of questions. So here's my background. I got a PhD in clinical psychology from Case Western Reserve, did a pre-doctoral internship at the University of Virginia in Charlottesville at the medical center, and then a postdoc at Shepherd Pratt Psychiatric Hospital. Worked with Kaiser for over 30 years and got very involved, ended up with a specialty in anxiety, which I really love treating. And then in 2008, I really read an article that just changed my life. I read an article by Skip Rizzo that said that exposure using virtual reality was as effective and often more acceptable to clients than exposure in vivo, in real life, which is, the gold standard. So I've been using virtual reality. I started using it in 2010 in my clinical practice and was just blown away with how effective it was and how quickly it worked. So when I left Kaiser and went into private practice in 2013, I absolutely wanted to offer this to my clients. Now, we're going to talk today. You're going to hear a couple of things. I'm going to cover some main points. But if you want more information, here are some more places to get info. There's a podcast where I talk about the use of VR in therapy and give a case example. There are 2 articles you might be interested in reading, and they're both open access, so you can just go directly to them, and the URLs are there. I'm working on a therapist guide for incorporating VR into treating anxiety in collaboration with Debbie Bolt of the National Mental Health Innovation Center. And we're nearly done with the writing. So we're in the looking for a publisher and getting the raw material edited. And I have just published a client workbook for overcoming anxiety and panic that talks about how VR can be a part of treatment. So if you're treating patients or clients with anxiety and you want to help prepare them for VR, particularly VR exposure, that could be a resource for you as well. But getting down to what we're going to cover in the webinar today, we're basically going to cover 4 key topics. One is, what are the options and what are the pros and cons? What are the strengths and weaknesses of each? We're going to address, why is every therapist not using VR? What are the obstacles? What are their concerns? What are people's concerns? And then what are the facts? What's the evidence that supports or counters those concerns? Then we're going to talk about why therapists do use VR, the research, the clinical benefits, what it's like. And finally, we'll just briefly touch on business reasons and how adding VR to your practice can really make a difference to you as for business purposes as well as for your clients. Okay, sound like what you came for, I hope. Okay, great. So many of you are using VR currently. Oh, fabulous. A clinic just purchased it. Great. And some of you from all over the world. That is so marvelous. So marvelous. And of course, I'm going to focus on the uses for anxiety, but the uses for substance abuse, for addiction, for eating disorders, it's just more and more we're seeing these applications. Yeah, Mike's saying he uses limbics in 50% of his clinical work. That's absolutely been my experience. You get this tool and then you find yourself using it more and more and finding more and more applications. All right, so let's talk about who the options are. What are the options and pros and cons? So you've got virtual reality, you've got augmented reality. We're going to talk about pros and cons and where you can buy the options. This is like VR 101, right? Technically in virtual reality, software creates a 3D virtual environment. You put on the headset and you're completely within that use. Excellent question about evidence-based results for VR with substance disorders. And yes, there is use for that. And if we have time, I'll talk a little bit about what the results are. And see, I've got a fairly extensive bibliography that I'm willing to share with people if you email me. All right, so Basically, beauty of VR is that it shuts out the current environment, so you're not in the office imagining something, talking with your therapist. You're really there. It can either be VR video, so it's a video that's three-dimensional, or it can be completely computer generated or half and half. Here are some examples of what it would look like. This is a completely CGE VR, and you see these are avatars. These are computer generated people. On the other hand, if you take a look at the limbics, this is a real car going over a real bridge, and when you pause it, you can look around and see what's there. Now, what about augmented reality? So VR cuts out your current reality entirely and places you in a whole other reality. It's all around you. Augmented reality, you take the phone as if you were taking a picture, and looking through, you see you're in your current reality, but a computer-generated object is projected into your current reality. So Pokemon Go is sort of the classic example of that. Here's an example of a augmented reality. I find it particularly good with insect phobias. So let's talk about pros and cons. So completely computer-generated VR, three-dimensional virtual environments. They're totally immersive. No matter where you look, you are in the environment. No matter where you look, you don't see your current real environment. It gives you maximum therapist control because every variable is created by the computer. That means that you can individualize it to the maximum extent. One company that makes this also has an option of playing it in Spanish, which is nice if you treat a lot of Spanish-speaking clients, particularly since I don't speak Spanish, but I do treat people who are bilingual, but for whom Spanish is their primary, their first language. So what are the cons? Well, they're avatars. They're not real people. It's not real settings. It's not a real bridge or a real car. Exactly. Mike's making the point that how much they enjoy the real-time footage, that it seems more real, okay? Whereas in computer, you're on a bridge, but it's a generic bridge. You know, you're on a road, it's a generic road. So those are the pros and cons of completely computer-generated VR. What about 3D VR? So it's primarily video. It's also immersive. You look around, you're in that world. It's specific, real environments. It's real people. It's real places, real activities. And whereas if you stop a computer-generated virtual environment, the screen goes black. But if you stop a VR, the screen stays there. So, for example, someone who is terrified of driving over bridges, I got them driving midway on the Golden Gate Bridge, had them stop. One of their fears was that the car would just be blown off the bridge, or that they might suddenly, if they had an accident, they would just go straight through the guardrails and over, or that the car would flip over the guardrails. Well, this person was able to turn their head and see out the passenger window how high and how sturdy those guardrails were on the bridge. You can't do that in computer generated. Now, what are the cons? Everything has pros and cons. Well, the cons are you have far less ability to control. It's a videotaped video. It runs. You can stop it. You can start it, but you can't. You can only occasionally change a few variables. Now, in the public speaking or job interview, you can change the whether the people around the table wear formal clothes or casual clothes. You can change their response to you, which is really wonderful. You can change with the driving, whether it's day or night, sunny or rainy. So you've got some control, but it's more limited. And then again, it's a video. So if there's movement, there are people who are very sensitive to movement, and it can create nausea. So if that's the case, I'll sometimes have people close their eyes during the movement. It doesn't seem to happen when you're driving. And I think the reason for that is that we are used to kinesthetically being seated and stable while visually we're moving, because that's what happens in a car. You're kinesthetically not moving, but visually you know that you in the car is moving. So I don't see that an issue with driving videos. Whereas I saw it more with the video where, the video has you walking, but your body is seated in the office. People seem to have more nausea with that. There are also 3D VR photos. Again, these are real. They're immersive because they're 3D. They're vivid because they're real, and convincing because they're real. The con is that they're less immersive, but on the other hand, that's a pro. If you need a lower level of exposure, this is a wonderful way to start. So augmented reality, pros and cons. Well, it incorporates the current environment, which can, again, make it more real. If I have a spider on my hand on my desk, that feels like a real spider. I really, like I said, I think it's especially good for insect phobias. It's generally less immersive than VR, than a whole virtual environment. I'd rather have one little spider sort of on my hand or next to me than in a room with spiders very close to me. So it can be an easier level of exposure, can start the treatment. So where do you get VR? Well, there are 4 companies that create virtual environments specifically designed for psychotherapy, which I think is important. I've listed them in alphabetical order. So just to understand, that's what the listing is based on. I threw in Invirtuo because I'm being very thorough. Invirtuo comes out of Canada. It's out of a research lab. It's kind of a not ready for prime time. On the other hand, and their manual is a little difficult to use. On the other hand, it comes in French as well as English because it's out of Quebec, I believe. And if you work with people who are French native speakers, that could be a plus. Secondly, it has an environment that is associated with sexual assault. Invirtuo is interesting because it's all computer generated, but they then created videos with the computer generated avatars. So you don't control what happens. You can just play the videos. It has limitations. It has several limitations, but if you're looking for something that has to do with sexual assault, this may be something that you want to look into. There's Limbix, which of course you're all very familiar with. There's Psyos out of Barcelona. They do, a mix of VR with VE, some videos. There's Virtually Better out of Georgia. They've got great graphics. They're all computer generated, and they're the only company that has war-related PTSD. Although if you work with veterans and you treat war-related PTSD, look into Soldier Strong Foundation, because my understanding is that they have created grants to help. I don't know if it's individual practices, it may just be clinics or VAs, but that they will underwrite the cost of the hardware and software. So those are the key vendors. Now, when you're thinking about what to purchase or what to lease, there are a couple of things to take into account. First of all, think about, who do you see? Who do you treat? What issues do you treat? What content do you want? What content do you need? That's your first question. That's the most important question. After that, then look at the cost, look at the business plan. Do you buy? Do you lease? Is the equipment wired? Is it wireless? Does the equipment require a strong internet connection or not? There are some hospitals or clinics where they don't want anything that's on their internet. So that may be a deciding factor. So here are some of the factors to take into account when you're making a decision. I would also say, whatever you do whatever lets you dip your toe into using VR, because honestly, this tool to offer virtual reality in the office is so versatile, so helpful, so powerful, and such a clinical advance that anything you do that gets you into it, I absolutely fully support. Okay, so why isn't everybody using VR? Well, they've done research on this and then follow-up research, and there are basically 5 concerns that therapists have. One is they think, well, the client knows they're putting on a headset, so they know it's not real, so it won't be real. And on the surface, that sounds very logical. So let's see if it stands up to actual data. Actually, no. It doesn't matter that you know it's not real. It doesn't matter that you know you put on a headset. The research shows repeatedly people respond emotionally, they respond physiologically, somatically. And what I hear over and over from my clients is, I didn't think it would be this real, or wow, it's so real. Or I remember one reporter who was interviewing me, and of course she wanted to try on the different virtual environments, and she's fine right up until we get to the heights. And I always warn people, please, please let me know if you've got a phobic reaction to something. And she was like, oh, I've got a little height sensitivity, but it's not a problem, never stops me. She put on, we went to the other environments, which were fine. She was like, oh yeah, okay, yeah, no, not a big deal, yeah. Went to the heights, she started sweating, she turned bright red, she said her knees started shaking. If the environment is relevant to you, it is evocative and powerful. So don't be fooled by the fact that if you don't respond to environment, nobody's going to respond to environment, because that ain't the case. So the other concern, second concern, is that therapists said, well, they worry that, yeah, it'll change in VR, but it's not going to generalize. No, like that Skip Rizzo's article in 2008, it really says what you do in VR translates to IRL. You know, this is not Vegas. VR is not Vegas. What happens in Vegas in VR, it transfers to real life. So I've given you some of the key references if you're interested in going to the literature. And I just want to tell you what my clients tell me. You know, the impact, the change in their lives, in their functioning, in their responses, in their cognitive and emotional responses is just mind-blowing. I just can't tell you what a difference it makes. I have people who can fly, who used to throw up or get drunk or sob their way through flights. I have people who are speaking up in work situations and taking promotions who would call in sick to avoid a phone meeting. Exactly. I would see people who were like gripping the chair and then relax. People who are, you know, able to enjoy and who get freedom. All right, so even though they know it's not real, they respond. Even if they change in VR, yes, they change in real life. So then it's like, oh, well, they're not going to want to use it. It's going to be too weird. It's going to be too techy. They're going to feel like it's going to be too immersive or too scary. Now, there is some basis for this. I don't use implosive therapy. I understand that there's research that it can be helpful. If you've got a client who's willing to do it, okay. But my own feeling is I reassure every one of my clients from the very start, yes, treatment may involve, has got to involve facing your fear, but I am not going to throw you into something before you feel ready. I'm not going to throw you in until we've got the knowledge and the skills and the tools for you to handle it and be successful. So I think that reassurance makes perfect sense. Now, that being said, people of all age, I've treated people in their late 80s, and I generally see adults, but I see occasional teenagers. research has shown it works with kids, it works with young adults, older adults, elderly adults. It doesn't matter your gender, your ethnicity, your nationality, your SES. It's not in Czech. The only languages I know are primarily English. The one that has Spanish, SIOS has Spanish. Invirtuo has a few, very limited, but it has it in French. On the other hand, the beauty of this is that it is immersive, okay? So that it's really facing the environment. And if you speak Czech and they speak Czech, you know their fears. You can be voicing their fears, helping them voice their fears. You can speak for the other people in, say, a social anxiety or a job interview. So the language doesn't have to be built in. And in fact, there are times when I mute any built-in language and I just talk to my patients, to my clients constantly, pretty much when they're in VR, to make it vivid, to make it relevant to them. Oh, there we go. And Limbix has translations. Cool, cool. All right. And this is what clients say. And I have to say, I start out with maybe 10% of my private practice patients coming to me. We're up to, it was 50% when I made this slide. It's probably up to 75 or 80% now. This really brings patients to you because they're looking for it. They're searching for it. So then they work, it's going to be hard to learn. It's going to be hard to use, or I don't do exposure therapy, or I don't do CBT, or, well, there are all kinds of ways that you can use it. First of all, it's gotten way easier to use. The tools are intuitive. You don't have to memorize and learn everything at once. You can start out with just what you need, and you can learn as you go, as it's clinically relevant. And it's not just CBT therapists who use virtual reality. One of the research studies showed that psychodynamic therapists were using it. DBT therapists, acceptance commitment therapists, therapists who do a lot of mindfulness. So which interventions? So I'm going to get to that. So Viviana, there are a lot of ways. In fact, that's the next slide in many ways. You can use it to increase hope and engagement because they've read about it. They know that it's going to be helpful. I use it as a reward because there's some very calming, soothing, relaxing environments. And those environments can help them relax more deeply. It can help support their self-soothing skills. You can learn and then practice skills either in relaxing environments or more and more challenging environments. By putting them in environments that are relevant to them, it can uncover fears that they hadn't articulated before, that maybe neither you or they knew were there and would otherwise have undermined treatment progress. But this, because they're there, it's more vivid, right? And so the fear comes to the surface. Obviously, it's amazing for exposure, for facing fears, for overcoming fears, for applying skills, because you put them in the environment. And then finally, I find it particularly useful for relapse prevention, because once they've overcome their fear, once they feel comfortable, once they can change their narrative about what's going on, can detach from any somatic response, can cope better, then I'll say to them, all right, I want you to make yourself as scared as possible. And I'll start voicing all their fears. Everybody's looking at you and they're noticing that you're anxious and they're thinking, man, this person is just a real idiot. Why are we even interviewing for that job? They'll say, man, you look so nervous. Are you psychotic or something? Or whatever their fear has been. And what they'll often find is their anxiety level, which I measure on a 0 to 10, maybe it only goes up to a 2. Whereas before, thoughts like that, it would have been a 9 or a 10. So that also reinforces and proves for both of us how effective treatment has been. And of course, nobody's going to say stuff like that in reality. So they have overcome and practiced and are no longer frightened by things that are worse than they're ever going to see. So anyway, it's got lots of tools, and there are emerging uses. Research about using it for depression and self-compassion. VR for substance use. Limbix has got the VR videos. I love those VR videos. They're working on virtual environments for eating disorders and body image. And I think it may be Giuseppe Riva, who is doing a lot of work with eating disorders. You can use it for social skills, to develop empathy, for people who are on the autism spectrum. Obviously, they've been using it for pain control for years. They're developing rehabilitation VR. Some people are using it to try and develop mindfulness and more sustained attention for people with ADHD. And then Daniel Freeman out of Oxford is using VR to help people with schizophrenia and paranoia talk back to their auditory hallucinations and challenge their paranoid thoughts. So what's the final hurdle? Well, the final hurdle is going to cost too much. And honestly, the cost has dropped dramatically. When I started in 20 grant, and it was $22,000. Now we're talking at most a few thousand maximum. You can get headsets. If you need a separate headset, you can get a headset on eBay. Vendors offer different pricing options. Again, if price is a big issue for you, find something that you can start with that's within your budget and go from there. You can also think about, is it going to bring you more clients? You can also think about, can you raise your prices because you're offering a service that maybe is not available anywhere else. I've had people fly in from out of state to see me because I offer VR, and that's what they want. So you've already heard some of the research support. Let me go through all the reasons, and you certainly hear my enthusiasm. What are the benefits of VR, right? It's immersive. It's real. They're there. They're not imagining. They're not talking. They're not right. You're actually there. We know that it triggers a physiological, emotional, cognitive response. So clearly the engagement in therapy and the affective engagement increases. And no matter what therapy you do, you want people who are affectively engaged. So even if you just use it for relaxation or for reward, it increases the therapeutic alliance. It's very well accepted. Of course, we talked about some of the multiple uses, and that it's uniquely suited for exposure because you can control the intensity and the pace of the exposure. And meanwhile, you're not out there in the real world, which raises issues of cost and time and privacy and confidentiality. You are there with them, guiding, supporting, monitoring. You can help them use the tools if what they're doing isn't working. If you purchase a commercially available VR set, is there software available? It depends on the company. Contact the company and see what software. Sios, for example, requires a Samsung Gear VR and an Android phone, which you can probably get on eBay for cheap. Let's see, other benefits, right? You can pause, you can repeat, you have more control. And again, like I said, they get to actually try it out in what feels like real. So the both of you get to see before they're out on their own in real life, you get to see, is this working? Has treatment been successful? Can they successfully apply the tools? Let's see, what else? Yes, and we talked about bringing fears and how it helps with relapse prevention. So this is how I understand anxiety and how I explain it to my clients, that there are a number of triggers in the absence of actual danger that can trigger fear, worry, panic, anxiety, that any of these triggers, from genetics to stress to past trauma or what I call unhelpful lessons from past events, can send a message of danger or threat to the amygdala, which simply reacts unthinkingly, triggers adrenaline, so you get full or partial fight or flight, anxiety, panic symptoms, and floods the mind with thoughts of fear and danger, worries. The instinctive response to this, which is hardwired, is to fall into these actions, to start to run away, to not go back and avoid, to become hypervigilant and looking for danger, watching out for the what if, watching out for the body symptoms of panic, start to take safety actions. And, I'm going to carry my fast-acting benzo with me all the time just in case. I want to have water in case my throat closes. I only want to sit on the aisle of the plane in case there's not enough air. And then, of course, people try and fight the anxiety response out of fear. Relax. I need to calm my body down because otherwise something horrible will happen. I need to not think this because otherwise something bad will happen or I'll go crazy. And if you fight it out of fear, all of these are fear-based actions, which of course complete a vicious cycle, and you're more likely to have the fear response go off. So what you want to do is you want to break this cycle by decreasing as many triggers as possible. And that's where work with past trauma, work with object relations, work with lessons from past experiences comes into play. It's where stress management comes into play, mindfulness, relaxation, acceptance. It's where cognitive and behavioral changes, better self-care, better self-talk comes into play. And let me get back to the question about software as we race toward the end, so I make sure you guys have all time. If I don't get to it, remind me. All right, so you've got to have tools to deal with the physiological response, which is where relaxation, diaphragmatic breathing, mindfulness, distress tolerance can come in. You've got to change your response to the fears. If my neighbor comes into me in the middle of the night and pounds on the door and says, get out, there's a fire, I want to know if there's really a fire. If there's really a fire, if the fear message from my brain, my neighbor is correct, I got to get out. On the other hand, if my neighbor just saw, I don't know, smoke because we were having a fire in the fireplace, I want to be able to determine, is my sense of fear realistic or not? So you have to identify and articulate all the fears and all the assumptions, and then you have to be able to evaluate and counter and challenge them. That's what they're able to then, that gives the clients a tool they can use when they then face the fear. Because bottom line, you can't get over a fear you run away from. So you got to know the facts so you can act on the facts, not the fear, accepting that there's going to be fear, that it's going to feel like you're taking a risk. And you'll start to treat these experiences as what I call an AFOG, A-F-O-G. And in English, that's another, you can translate that F any way you want. Fabulous opportunity for growth, which then is how this brain starts to learn there actually is no real danger. Can't learn from just talking to it. It's got to go see for itself. So what are some of the uses, right? We talked about increases hope, increases engagement. It can be used as a reward. It can be used to help you relax and self-soothe. It can teach skills. It can help you practice skills like diaphragmatic breathing, progressive muscle relaxation, mindfulness. It can help uncover fears. It can facilitate interoceptive exposure for people who are frightened of the somatic experience of panic. There are a series of exercises, physical exercises that you do that create similar sensations in the body. And you can do those and then have those happening in the body as they go into the environments that frighten them. So if you're afraid that if you're panicky and have somatic responses when you're driving, you might have them do an exercise like running in place that gets their heart going and then put them in the driving environment. Let's see, can you add the therapist voice into the experience so you don't need to be with them? I don't know how you could do that, but all right, we'll save that for later. I also have to say I like to do in-office work, because then I get to see if somebody's started crying or turning a little, or clenching their fists, and I'm physically present with them to help ground and support them. So we've gone through a lot of the clinical stuff, and let's just talk about business. You like to have the headphone using the VR connected to the microphone so they can hear you shutting out the outside noise. Absolutely. If you're in a noisy environment, I happen to have the incredible gift of having a very, very quiet office. I don't know if you can see the garden in back, but it's wonderful. But yeah, if they can hear you and shut out the outside environment, so they're more real, they're more immersed, that's all good. In terms of helping your practice, it creates a niche. If you're in private practice, you stand out from your competition. You're meeting a growing need. People want this. People are searching for this. And so the clients who come to you are also motivated clients, which of course is fabulous. They'll work with you. They're ready to respond. They have a high expectation that therapy will work. I've had some clients that come in for focal treatment and turn into long-term treatments. On the other hand, when I was working at Kaiser and we just had to see patients all the time, and there were new patients every week, whether or not you had room for them, VR was an incredibly helpful tool because it helped people overcome their issues so fast that I had space for the new people who were coming in. As a matter of fact, it worked so quickly that I offered to do the exposure piece for other therapists' patients, which I got to tell you, nobody makes an offer like that. What else? I will often have other therapists will refer their clients to me. The clients are in longer term therapy with the other therapists, but coming to me for more focal adjunctive work. You can market to MDs as an alternative to benzos, which most MDs nowadays are becoming less and less comfortable prescribing long-term benzodiazepine use because, it's addicting. And then of course you get satisfied clients. I would love to hear from you. I would love to be able to email you when the therapist guide for using virtual reality with anxiety comes out and is published. And I can actually offer a limited number of free review copies of the client workbook that just got published. So if you email me at my very long but very simple email, Elizabeth@elizabeth-mcmahon.com, I will be happy to get back to you. Okay, so let's see. There was a question earlier about what would I like? And there was also, all right, behavioral health. Oh, no, that's John. Okay, questions about limbics. Oh, that's fabulous. Wow, working with traumatic brain injury. All right, so what software would I like to see? Yes, it could be really fascinating, Rebecca, to see the EEG and the eye tracking. I haven't used that tool. Which interventions work best with VR? Well, I specialize in anxiety and the full range of anxiety, and depending on who you treat, you could use it for OCD, flying fear, social anxiety, test anxiety, public speaking anxiety, claustrophobia, height phobia, driving phobia. If someone's had a car accident and now they're frightened to get back in the car, it can be helpful. I've used it for people who come in so frazzled they can't focus. I put them in VR, they calm down, and then we can do therapy. I use it to help them learn some of the coping skills. either playing a recorded instruction while they're in a relaxing environment, or talking to them and maybe having them record my voice while they're in that environment, which makes my instructions more powerful. And then, of course, using it to help face a phobia, to get over fear, to face whatever you've been avoiding. It is unparalleled in terms of its usefulness and success. Let me see. What other questions? I know there was something I was going to get back to. Okay, people liking the real-time footage. We talked about evidence-based. Yeah, there's definitely evidence that it works with substance abuse. You can use it both for, again, self-soothing and for practicing refusal skills. So someone's, like Limbix has got a VR video where, a series of videos where the bartender says, here, have one on the house, or here, this is a special drink. And he's in a bar, you're around other people who are drinking. All those cues to go back to using are there, and being able to tolerate them and not give in. All right, what would I like to see? I'd like to see better VR for heights. John, I think Limbix is working on this, right? And what else? Upgrade hardware. Okay. Oh, what else? Maybe more for teens. I know you got something for needle, which is needle and blood injury phobia, which is great. I actually had somebody who would pass out, but wanted to go into a healthcare related field. That person was very motivated, and within 3 sessions had, combined with what's called applied muscle tension, had gotten over the phobia and no longer passed out, which was really, really exciting. Couple of technical issues, some suggestions. The lenses can fog, so I keep alcohol wipes and a lens cleaner. Yeah, working on heights. Yeah. All right. What else would we like? More driving, more driving. More public speaking settings. Yes, software swimming, being underwater, that's an issue. That's an issue for some people. Now you're going to see VR apps. There are thousands. At this point, there are, I don't know, over 10,000 mental health apps, and now VR apps are the current thing. Here's the deal with apps. Most of them have no research supporting their actual effectiveness and their claims. There is huge push, get your app, out there to make the claims, to do PR, to try and make. I have heard app developers say they went to a hackathon and were told, don't wait for any kind of research or validation, just get it out there. I'm like, guys, that's not. I don't think it's a good business model, because if it doesn't work, it's not going to sell. But B, it's not ethical. Some apps are created by people with the best heart and the best intentions, but they don't have any experience, licensed mental health therapists working with them. On the other hand, it can provide some adjunctive education. It can help them reinforce some treatment skills. I kind of think of it as similar to a self-help workbook. Self-help workbooks can help clients prepare for therapy, benefit from every session. It can help with relapse prevention. But the apps are not individualized. And self-care is self-care. It's not the same as therapy. Although Daniel Freeman is doing research and he's creating apps. He's got an app that he's testing to help people who have heights fear. All righty, good. What else? Yeah, visual drift, that was bad for motion sickness. Yeah. Okay. So there's a comment here where John's saying to Mike that their manta ray environment is good for swimming. What I would say to you is think about the content of the VR. Whatever company's products you use, and I would encourage you to expand and just dip your toe, get something, and then keep looking. But don't just look at the label, because the label, if I use, say, driving, fear of driving, you're in the car, you're going over the bridge, could be good for fear of driving, but it also could be good for fear of heights, or it could be good for fear of being alone, or it could be good for dealing with the grief of a breakup and you used to drive with your significant other and now they're not there, or the grief of a death. Or it could be good for claustrophobia because you're in the car and you can't get out, right? Think about the content and the use of the content. Don't just stop at whatever the VR content is labeled as. All right, so we got 8 minutes. Show the slide that lists the manuals for exposure work again. I would be happy to, and if you email me, I would be delighted to go and send you information about those books. So here quickly, speaking of creating nausea, there's the podcast. If you go crazed podcast, it's number 5. Here are the articles. Here's the therapist manual that's going to be coming out. It's in progress. Here's the workbook that is currently published, as of last month, I might say, and available almost worldwide through Amazon. I know Amazon in Italy, Germany, France, the UK, as well as the US, maybe a couple of other Amazon sites, and can be ordered through a bookstore or a school or a library from Ingram book distributors. But if you email me, I'd be happy to go over all of that information. What's the biggest challenge to scaling VR for therapy? What skills would you need? John will answer about whether or not they can get a copy of the slides. The skills you need are, you need to be able to treat without VR what you treat with VR. If you don't know how to teach relaxation, don't just rely on what's recorded. If you don't know how to treat anxiety, get training in treating anxiety. And then the VR is a tool. So VR is a tool, not a therapy, but it's a wonderful tool. And let's see, what's the biggest challenge to scaling VR? Brenda, could you maybe expand on that a bit? I'm not sure I'm quite following. Oh, you're very welcome, Sean. Thanks for being with us. In terms of scaling, I certainly highlight it on my website, and so people can find it. I put the fact that I offer virtual reality therapy in my email signature. If you're talking about scaling in terms of, oh, thank you, John. If you're talking about scaling here, and I'm going to type in, and my email is Elizabeth at elizabeth-mcmahon.com. Let's see.
So people can do things.
Right. Right. There was an answer about, is it available, a question, is it available in Arabic, or can you use it with their Arabic speaking clients with its English format? I think, yes, if you as the therapist can read English enough to control, to handle the controls, then yes, you can use it in any language, and you contribute, you as the therapist can speak whatever else they need to hear. I'm not explaining that well. So like in a social interaction, you don't have to rely on recorded, on the avatars or the recorded people saying something specifically. You can mute the microphone if there are recordings, and you can speak what the avatars say, or you can speak for the other person. And that way you can also tailor it and individualize it so that it fits your client's needs. Okay, what else? These are great questions, guys.
Yeah. Keep them coming.
Yeah.
Thanks for doing all these questions. It's so fun to see everybody chatting away the whole time.
I think it focuses on acute pain, but I think there is some people with chronic pain not only get an immediate relief, but for some, the relief seems to expand over time. I think probably you're just breaking up some of the neural circuits that have been set up. But pain is not my subspecialty. Yeah, using VR exposure for people who stutter, yes, so they're not avoiding, so they're making eye contact to deal with the anxiety, to decatastrophize the stuttering. Absolutely, absolutely. I love the way that you're using this. It just highlights what a flexible tool this is. I guess.
I think there's a great question about reluctance to use VR. In my own experience, just with our own clients and demo base, I find that, about 3% of our clients will have some sort of issue. There are some things that maybe less for Elizabeth because she's got the magic touch. I find that, you really have to have a high frame rate to make these VR experiences not so nauseating. So you want to have a frame rate that's faster than our eyes process, so that when we turn, the world updates in real time. If there's any lag in that, it's very nausea-inducing. So, we recommend at least 50 frames per second when you're working with a VR device. Limits
I'm finding that there used to be
it's just much faster than our eyes process, and so
that the frame rate has increased, and so that's decreased the nausea. And that for example, with Silos, when they're moving the client from one place to another, they black out the screen and then they put them in the other place. So I'm finding nausea was never much of a problem, actually, even back in 2010 when it was really, yeah, I know, pretty amazing. But less and less of a problem now. It really has been a non-issue in my practice, which is cool.
This question from Heather is about the large therapy office. I'm not sure, Heather, do you mean about like logistically? Because logistically, this is pretty small. We try to keep this easy to use and compact. But, or is it more about sitting, like having enough clients? Is that what you're asking about?
It used to be using it actively. Do clients move around with it on? No, they shouldn't be, because the avatar, or they are moved in VR. So they should be just sitting or standing. That being said, I've occasionally had clients who are working on heights phobia, and I will have them walk a little bit, stand on one foot, squat down, lean forward, to have them test that they don't actually fall like they are afraid to, that they fear that they will. But mostly they shouldn't be moving. So you can do it sitting or standing. You don't need a large office. You don't need a lot of space. They're not moving around. So clients are not reluctant to use VR. And if they are, I'd want to ask why. I think they'd be afraid that you would throw them into something that they weren't ready for. So you should not do that and reassure them. Therapists are reluctant for those reasons that we talked about, and the research doesn't support it, and the clinical experience doesn't support it. So yeah, if you have any other questions, let me know. I stand up when using VR. Exactly. If the avatar is in a standing position, I have them stand in a standing position. If the avatar is seated in the VR, I have them sit. So I have them sit for the car, but I might have them stand if they're presenting.
So these examples Elizabeth's talking about, which are standing or sitting, they're really best suited for 3 degrees of freedom VR devices, which is mostly, I think, everything Elizabeth has recommended today. One thing that's exciting for the future is now that Oculus Quest has come out, we're seeing standalone VR headsets where you could potentially walk around in them. To do that, you have to have cameras or some sort of tracking on the outside of the headset that knows if you're about to walk into a wall or something like that. So there are some safety concerns, but I think it sounds like sitting is
so I'm typing
easy,
some things that I do that I see are really key in the treatment. Have them tell you their fear level. Okay, so we're talking, SUDS, and I use a 0 to 10, where 0 is basically no anxiety and 10 is extreme anxiety, so that they and I can both monitor, and then I can reinforce. Man, the last time that you were presenting, you had an anxiety level of 7, and now it's down to a 4. What did you do that made that possible? So highlight and have them tell you what skills they're using that work. And yeah, the more they talk, the more real it is. And that's what you're going for. Real and engagement and interaction. And VR just makes that possible. Thank you so much for being here. I appreciate your time, your attention. You're taking this out of your busy day. Oh yeah.
Elizabeth, if you have time for one more, I really think Lisa just asked a great question about how do you handle an overactivated
and
client.
We stop and we slow down. I really try to avoid that, and it's really only happened twice. So it depends. I could bring down the stimuli, I could stop immediately, I could put them in a different environment, we could get them out of VR and process what happened. Any of those, depending on what the client's response and the client's issue. Yeah, but it's like, in essence, it's the same thing you would do if somebody got too emotionally distressed when you were talking with them about something. You'd stop, you'd say, what's going on? You'd process it. Maybe you'd back off. Maybe you'd break it into smaller pieces. It's the same skill.
Elizabeth, thank you so much for spending an hour or more than an hour now with some potential VR therapy practitioners or enthusiasts. I'm sure it seems like there's a lot of different folks on the line. I think she was looking at the polling, and we've got a good mix of people who are both therapists as well as researchers, and a few in the others types of categories. So really nice of you to share all of your wisdom from the things you've learned the last 10 years. And thank you, all of you attendees, for engaging so much on the chats and asking us questions. This is really fun. I know we had a first couple of minutes of technical difficulties, or I'm muting myself, or I'm calling Elizabeth. So clearly, this is our first webinar. We have some room to grow.
Take care.
But thank you for
definitely be in touch.
Everything, everybody.
All right. Bye.
Okay. Bye, y'all.